So we'll move on to the next talk. The next talk will be delivered by Dr. Fahim. He's going to talk about culprit versus multivessel PCI in STEMIs. Fahim, please.
Thank you, Jack. Can you all see my slides and hear me?
Yes, good.
Okay, super. Well, my job, first of all, thank you for the invitation. Thank both the Bangladesh Society of Cardiovascular Intervention as well as the Asia Pacific Society for inviting me. My job in the next, 10 to 12 minutes is to talk about multivessel PCI in STEMI and, how do you approach it and what do we do? I don't have any conflicts of interest. So we're going to review some of the data on multivessel PCI and STEMI in a sort of an objective manner or maybe a slightly critical manner, and touch on the role of physiological assessment of the non-culprit vessel. And then also briefly touch on cardiogenic shock. It's already been discussed by Ramesh, so I don't need to go through much of that. And then briefly my approach. So we all know, I think all of us who are interventional cardiologists are aware fully that multivessel disease is common in STEMI, ranging from as high as 50-odd%, and the prognosis, not surprisingly, is worse. So there's nothing new there. The question you have to ask is that, is there a rationale that favors multivessel PCI in STEMI? And the answer is, logically, yes. I mean, if you think about an infarcted territory that you've opened with primary PCI and you have a tight lesion in a non-culprit vessel, you worry about remote ischemia. And we all sort of kind of believe that remote ischemia tends to be bad. These are acute patients. This is not the ischemia trial group of patients where there's stable disease. So we worry about remote ischemia. So it makes sense to open it up. And of course, we also worry about the fact that non-culprit lesions are often also vulnerable and hot and are not stable, as you see in the stable ischemic heart disease cohort. And then another issue, which is more relevant to developing rather than developed countries, is cost containment. Often patients are paying for procedures out of their own pocket, and bringing them back for another procedure is challenging. Just the economics, the money factor becomes important. The other question we then have to ask is that, is there a rationale that opposes multivessel disease in PCI, in STEMI? I mean, just from a logical standpoint. And again, once you've opened up the culprit, what do you do about is there a reason to not open the non-culprit vessel? And one is, of course, vasoconstriction. We know from a lot of data that there is vasoconstriction going on in all the vessels, and you often overestimate non-culprit vessel stenosis in the setting of STEMI. Also, do you worry about issues with contrast load? The contrast, you don't want to give more contrast. They can go into heart failure, there can be kidney issues. And then the P2Y12 drugs like ticagrelor or Plavix, et cetera, have not kicked in. And so when you put in more metal, you worry about stent thrombosis. And the fact that, at 2 in the morning, we're all human. Who wants to do more work, when you've already done a stressful procedure? And perhaps the most important rationale is the issue of safety. Is it safe to intervene on a non-culprit when you already have an infarct going on the other end? And this is just a quick illustration of a case we did very recently, maybe in the last 1 year. 60-year-old guy with inferior STEMI. We fixed the RCA, no big issues there. Everything went well. And the LAD had a severe set of lesions, as you can see. Now, we waited for a couple of days, brought him back over after the weekend, to open up the LAD. The patient had already been on ticagrelor, so 3 days of time to cool down, rest, good antiplatelet therapy. And after the first inflation at just 8 atmospheres, look what happened to the artery. The flow went down, the blood pressure went down, the ST segments went up, and of course, I was diaphoretic. Of course, we recovered a lot of adenosine, the flow got better, and we opened up the artery with a good result. But the point I'm trying to make is that non-culprit lesions are often hot and unstable also, unlike in stable disease. And so if you develop no reflow or slow flow at the time of the STEMI PCI, it could be very poorly tolerated. And that's something that you have to be very acutely aware of. Now, what are the approaches to non-culprit lesion in STEMI? And there's several. You can fix it right away or immediate PCI. You can do it before discharge, which we would call early stage PCI, or do it as we used to do in the old days, which is send home and bring back in about 4 weeks with a late stage PCI. or do the old-fashioned way, which is don't do anything, do a stress test weeks later, and then bring them back if they fail the stress test. Now, in the early 2000s, the guidelines on STEMI and multivessel disease were as follows, which was said that essentially fix the culprit vessel only during STEMI PCI, except cardiogenic shock. In that case, fix it all. That's what the guidelines said back in 2012. And for the non-culprit vessels, which what the recommendation was, by and large, to go ahead and assess the non-culprit vessel with stress testing, and then do a staged PCI in about 4 to 6 weeks. That's what the guidelines kind of said. That these are the European guidelines, these are the American guidelines, were all kind of said more or less the same thing. Now, since the 2000s, what have the trials tried to answer? What questions have they tried to answer? The first question they've tried to answer is, should we fix the non-culprit vessels early or not? And this is this is sort of a composite of all the data. We don't have time to go through each and every detail of the trial, but suffice it to say, we have the PRAMI trial in 2013, and most recently the COMPLETE trial in 2019, which basically looked at fixing the non-culprit vessel early rather than a delayed strategy. They all used a similar set of primary endpoints, which was a composite death MI with something else. They all treated the culprit vessel early, either in the same setting that was in PRAMI, or mostly, before discharge within the first, 2 to 3 days. Although COMPLETE did also treat some of them after discharge within the first couple of weeks. The composite of these trials was that there was a benefit, a significant benefit of fixing the non-culprit vessel early, but importantly, driven largely by a reduction in urgent revascularization, although PRAMI and also COMPLETE had a reduction in new MI. Now, based on this quick overview, the answer is, well, yeah, non-culprit vessel, we should fix it. The answer is yes. But the devil is always in the details. And I'd like you all to think of these trials a little bit more critically and see what's under the hood in the details. And it's important to always look at the exclusions of the trials. And the exclusions of these trials are quite logical, and I don't think there are any problems over there. They excluded cardiogenic shock, which is reasonable. They excluded left main thrombosis or stent thrombosis, and they excluded CTO. All those make sense. But there are some issues with these trials that I want you to sort of think about. And the first of all is the selection bias and sample size. And the sample size is not huge, even with the COMPLETE trial. So if you look at it, these are relatively small trials. Even COMPLETE, which was much larger, 4,000 patients, it took them 4 years and 140 centers to recruit 4,000 patients. PRAMI, it took them 5 years to recruit less than 500 patients. So what does that mean? That just means for you to say that these were relatively selected patients, and so they didn't include everybody. They, if we know STEMI is common, they could have come up with these numbers very, very quickly. So there's a bit of a selection bias in these trials. It's also important to understand that the types of lesions randomized is always a problem, at least in my mind. And why I say that is because the definition of a non-culprit vessel was something like more than 50% in PRAMI. In other trials, it was more than 50% with a positive FFR. And only the COMPLETE really systematically took lesions more than 70% or less if they used FFR. And that's always a problem to me because what does more than 50% mean? Is it a 60% lesion or is it a critical 99% lesion? The core lab was not involved in several trials, but nonetheless, at least 2/3 of the lesions in COMPLETE were about 80%. And so that's just important to keep in mind. And only 2 trials mandated FFR, but is using FFR really better? We'll talk about that in a second. The other issue with these trials that I want you to think about is that the control arm was undertreated. And what I mean by that is that if you have a STEMI, you fix the culprit, and you then have the non-culprit, as I showed you earlier, the standard of care was to do stress testing and then revascularize if the stress test is positive. Now, what did these trials do? They took these patients with significant non-culprit lesions like this one and just didn't do any stress testing and randomized them to fixing or just culprit-only PCI. And you can imagine then that in the culprit-only arm, there must have been patients who would have had a positive stress test, but ended up getting treated medically. And so what that means is that, and in the non-culprit, in the culprit-only arm, fixing the non-culprit vessel was actively discouraged in all the trials, PRAMI, Culprit, Compare Acute. They basically said, don't fix it unless you really, really have to. And so that sort of means that the culprit-only arm was disadvantaged compared to the complete revascularization. And so the trial was basically active therapy versus a wait-and-see approach. We all know that in our normal practice, we would have done ischemia testing on these. And what the ideal trial should have been, there should have been an ischemia-guided arm. And I bet you that if there was an ischemia-guided arm also, these two would have been similar and both better than the wait-and-see arm. But the trials were not done that way. So I just want you to keep that in mind. The other final criticism of these trials is that the endpoints were kind of soft, urgent revascularization, no benefit on mortality. But sure enough, the complete trial did have a reduction in new MI. But putting all that together, nonetheless, I think the bulk of the data still says fixing it is a good idea. Fixing the non-culprit in STEMI is a good idea. The next question then is that should we fix it based on angio or physiology like FFR? And if you look at the trials the two trials that included mandated FFR, Dynami and Compare Acute, sure enough, they did so, but these trials did not compare FFR guided versus angio guided. And that came from the Flower MI trial that was just published a few months ago, 1,000+ patients, randomized to either angio-guided or FFR-guided PCI. And the bottom line is that FFR-guided revascularization was not better than angiography-guided PCI at 1 year. So the question one, fix it, yes. Question two, angio versus PCI, which should you use to direct? I think both are equal. The third question is cardiogenic shock, and Ramesh has already addressed this, so I'm not going to go spend too much time on this, but the Culprit shock was published a few years ago. And the long and short of it is that fixing the culprit only at the time of the cardiogenic shock was better in terms of the composite endpoint as well as mortality. And people then said, well, maybe at 1 year, the mortality would be better. And their answer was no. At 1 year, the mortality was no different. And so for cardiogenic shock, it seems like you fix the culprit only and get out, do the rest as a staged procedure, don't do multivessel PCI at the same time, which used to be the older teaching. So what do the guidelines say now? This is the most recent guidelines we have. They come from the European group, published in 2019, which basically says, fix the non-culprit artery before discharge. It's a class 2A now. So multivessel disease, fix the non-culprits before discharge. Most of the time, a couple of days afterwards. And for cardiogenic shock, don't fix the non-culprit during primary PCI, do it at a later time. And this is a downgrade because just a year before this, the guidelines said for cardiogenic shock to fix the non-culprit at the same time if need be. So there's been a change. And so this this recently published paper sort of summarizes things that, back in 2010, culprit only was 2A. And now the guidelines have changed, which says that multivessel PCI is now recommended or class 2A. So what is my approach in the last minute or two? If I see a critical lesion at the time of STEMI in the non-culprit vessel, my approach used to be to send them home and bring them back in 2 to 4 weeks. Now I do it before discharge in the next couple of days. It is unusual for me to fix it at the same time just for safety and other reasons. What about a moderate lesion, less than equal to 70%? In the old days, we used to send them home, do a stress test, and then fix it if it was positive. In more recent terms, it has been to do an FFR at the time of the STEMI and then fix it a couple of days later. I think after Flower AMI trial, my approach will be to fix it before discharge, either doing FFR or just angio guided. I think both approaches are appropriate. So to conclude, ladies and gentlemen, trials of multivessel PCI and STEMI suggest that early revascularization is better, and that is probably true. But it's important to remember that the benefit is driven mostly by repeat revascularization rather than hard outcomes. But the recent complete trial did demonstrate a reduction in new MI, although no mortality benefit. And our approach is to fix the non-culprit vessels a couple of days later before discharge. Early intervention before discharge seems safe, although I would not do it in the same setting because of the reasons I've suggested. Patients can go south very quickly, but I also am fully aware that when there are cost constraints, when the patient has to pay for one procedure, Sometimes doing it at the same setting does make sense if it is a very simple procedure, but go in that direction with caution. The inclusion of, the cutoff of more than 50% is troublesome to me. And so I think it's important to consider using IFR, FFR if the lesion is really moderate, but the data, at least from Flower AMI will support fixing it also, but I would lean towards the angio-guided for really 70% and above lesions. And the role of, angiography-based physiology, in other words, non-wire-based physiology like QFR and AngioWorks is being studied, but it still needs definition. And finally, for cardiogenic shock, my advice is fix the culprit and just get out. There's a mortality benefit for culprit-only intervention and stage the other vessels later. Ladies and gentlemen, thank you very much for your attention.
Thanks, Fahim. Again, a great talk. We're going to start with a question from Dr. Aisha Kadir. Dr. Kadir, please.
Thank you. Thanks, Dr. Jafary. That was a really great critical appraisal of the trials. And I wonder if, given the heterogeneity of the timing of the second procedure, the non-infarct related, whether the upcoming trials should in fact investigate the timing of the second procedure, because presumably doing the non-infarct related artery at index or even week 1 would be far less provocative than doing it at, say, week 3, which is pretty much the range that was seen in the Complete trial.
Yeah, so I think Complete included, it was about a third that got it done, in a delayed fashion. I think when you look at the curves do start separating out relatively early. So I think there is enough rationale from the trial data to do it early. Now, is early 2 days? Is it 3 days? Is it, 7 days? I think that's going to be very difficult to tease out, and it will be a challenging randomized trial to do. But I do think that a good yardstick is before discharge, and obviously a lot of it depends on how stable or unstable the patient is. But what is the absolute optimal time? I think that's a question that will still need a trial, which I'm not sure we will ever see, but it's a good question.
Thanks, Dr. Kadir. Any other comments or questions from the panelists?
Yeah, thank you very much.
Jack 10. Dr.
Yes,
Jack 10.
Dr. Jamil. Yeah.
Yes, I am Professor Mir Jamal, Secretary General of Bangladesh Society of Cardiovascular Intervention. To Dr. Fahim Jafary, I want to know, because we were in the procedure that we should do the non-infarct related vessel later on in index hospitalization, significant lesion, if any, without the culprit lesion, but we should do the culprit lesion. But in case of acute myocardial infarction with cardiogenic shock, there was initially that we should do all the vessels, but now it is switched over to that only culprit vessel should be done. And initially, at the moment of primary PCI, we usually do not do the other vessels if there is significant lesion, because as it is a condition of thrombosis, so most of the vessels usually contains thrombus, and that is why it is better not to do the other vessels at the moment during doing the culprit lesion. And that is why they have declared to do it according to the guideline, to do it in index hospitalization. And my question is there, in what do we mean by index hospitalization? Patient remains 3 days, 4 days, 5 days. Shall we do it by 2nd day, 3rd day, 4th day? Is there any parameter, or is there any guideline to do on which day we should do the second one, if it is significant or if it is necessary?
Yeah, thank you, Dr. Jamal. I think that's similar to the question that Dr. Kadir was asking, is that what is the optimal time? And I think that we don't know. I mean, you could do it the next day. You could do, the average time is about 48 hours in most trials, because they really also want to get the patient home. And, if you have an uncomplicated STEMI, you fix, let's say, the LAD, and then there's a right, and at 48 hours, it's perfectly reasonable to do it if the patient is stable. So I think we will never know whether it's best to do it at day 2 or day 3. What the data says is do it before discharge. And so in our practice, we typically will do it in 48 hours and then send the patient home the next day. There are some colleagues across the world that they'll literally bring the patient back at 48 hours in the morning and then send the patient home that evening. So it all depends also on how comfortable you are and how stable the patient is. But in the first 2 to 3 days is the time frame that most trials have used. And I think that's what I would follow.
Any last question or comments?
Thank you. Fahim, this is Tamzid from Bangladesh. Actually, I always follow your approach. Even there was a trial showed multivessel PC at the same setting in cardiogenic shock. But of course, time is an issue. If you finish the procedure so quick and patient remains stable, it's not necessarily harsh to go for the other vessel angioplasty in the same setting. And obviously, if patient remains stable following the procedure and there's no symptom, then of course the question depends on how critical the other vessel lesion are. Then you go ahead with the stenting of the other vessels in the same admission, not in the same day, of course. But depending on other issues, as you say, can compromise. If the patient not critically stenosis, no critical stenosis, we can do further testing before certifying the patient before further intervention. That is what you believe. I believe as well as always. Even after this new statement, I think you already proved that we go for the single stenting in primary PCI, in cardiogenic shock as well.
I think cardiogenic shock, the important thing for everyone to understand is that cardiogenic shock, the teaching used to be fix it all at the time of the index primary PCI, because the thought was that you got to fix everything to improve the cardiac output. And the culprit shock showed that actually that is harmful. So it's important in cardiogenic shock, it's important to actually stage the non-culprits later because there's a mortality benefit for culprit only at the time of the STEMI. For the others, I mean, the only trial that did it in the same setting systematically was PRAMI, and they actually showed a benefit. But I think I always worry, at least certainly based on complete, it seems that you don't have to do it in the same setting. You can do it 1 or 2 days later. I always worry about safety. You know, if you fix the LAD in this anti-STEMI and now you do the right and the right goes down, the patient gets very sick very quickly. So I think it's probably better to do it at a later time. I do understand that in many healthcare environments, the cost issue comes in, that if the patient has to pay for one procedure, it's easier to get it all done in one go. But then there is a small but finite risk. In experienced hands like yourself, probably not. But in younger hands, it may be a bit risky. So my general advice is to do the culprit only and then come back in 2 days and fix the non-culprit.
Yes, so, I do agree with the safety of the things. Actually, cost is an issue in our country, obviously, because you do it a second day, even second procedure, there's an added procedural cost. Yeah. But generally, I mean, obviously, we have to think about safety of the patient. If there's a safety, that's the first thing you have to think.
Thanks. In the interest of time, we'll have one last question from Dr. Kadia, then we have to move on. Dr. Kadia, please.
Yes, I was wondering, would your approach change if this were pharmacoinvasive? Because the bulk of the procedures that get done here are not directly primary PCI, they are post-thrombolytic pharmacoinvasive, presumably a little more stable than a primary PCI setting. So would the approach change then? And is there any trial data to this?
No, it wouldn't, because my worry will still be the same, that, you know, they've gotten thrombolytic, they're a bit more stable, you've opened up the culprit. Now, let me qualify that. If you're doing the invasive procedure 6 days later, it may be now the equivalent of what a non-STEMI-like patient is. So you may be right that way. But a lot of the times pharmacoinvasive is they get thrombolytic and then they get cath the next day or even a few hours after the thrombolytic when they're transferred over, and you open up the culprit. I think it's safer to wait, in my opinion, and then just bring them back in a couple of days. But sure enough, if the time delay between your thrombolytic and your index PCI is now several days out, then you may have a point that it's probably safer to do it and treat this patient like a non-STEMI patient and get it done with.
Thanks, Dr. Fahim.